Hey guys, welcome to another episode of Health 210 Podcast. This is your favorite doctor, Dr. Mansoor again. And today I have an old friend of mine who is an orthopedic genius, Dr. Jamie Lynch. Jamie, thank you for coming here. How are you?
Thank you for having me. I'm super excited to be here.
And we've been trying to go back and forth with setting this up. Thank you for putting time for us. Jamie, I know you since 2017. Let's start off with telling my audience who Dr. Jamie Lynch is. You can start anywhere.
I'll start anywhere.
Yeah.
Right now, my passion is orthopedic surgery, focused on shoulder, sports medicine, all the way up to replacements, and with respect to knee, sports medicine. So ACLs, meniscus, cartilage defects.
Okay.
Favorite stuff to do. That is my work side, and owning or co-owner of True Ortho, which is an all-women orthopedic surgery practice in San Antonio, Texas. And we've been in practice. We've been going since 2018.
Okay.
And it's an amazing practice full of people that treat patients the way that I do, which is taking the holistic approach to patient care.
Okay.
Whether it ends up being operative or not. So to me, it's really important to have that. Now that's my work side.
Yeah.
And then I take my work side hat off sometimes and go home, and I have 4 amazing, beautiful daughters.
Okay.
That are 9, 7, and my twins are 5.
9, 7, and 5. Okay.
Yeah, and an amazing husband who, if I didn't have him, couldn't do all the things that we're doing. So my life is very full.
Yeah.
Running a practice and operating on people and fixing problems from a approach that if somebody comes in with knee pain, it isn't always caused by the knee. There can be so many different layers, and that's what I look for from the beginning.
You said that you have a practice that's all women-based. So who are your other partners?
So Dr. Amanda Marshall is a co-owner with me, and she basically started the practice in 18 when I still had to get out of my prior practice.
Okay.
And so we kind of coordinated, worked together, and then it was off to the races, basically. Dr. Naomi Shields is our foot and ankle specialist.
Yes.
And so she came along with us at the beginning as well.
Okay.
And Dr. Elena Brelin is it also does total hips and knee replacement.
Okay.
So I didn't say this, but Dr. Amanda Marshall does mostly knee replacements now. That's sort of her passion. And then Brelin takes knee and hip replacements, and Dr. Naomi Shields does all of our foot and ankle, which is excellent. So I get all the sports medicine stuff, and I get to do what I'm passionate about.
All right. And then are you based entirely in San Antonio, but where did you do residency, fellowship?
Yeah, so I actually started the process in Illinois. Okay. And started at University of Illinois and Chicago for medical school. Okay. Very close to my home, which is Plainfield, Illinois. Grew up there. Yeah, went down to Champaign for undergrad and then up to Chicago. Okay. So while I was in Chicago, University of Illinois was a great place to practice. I met some really great people within orthopedics, and I found out that ortho was the thing I wanted to do. I mean, I saw a knee replacement in medical school and just knew right away. And it's funny now because I don't like knee replacements at all. I don't want to do them. I have no desire, but I love that. I just seeing the power tools in the operating room and fixing a problem and letting people do what they want to do. Yeah. So that started it. And then I went to Northwestern for my residency, which was also in Chicago. Yeah. I had a fabulous experience at Northwestern, and then chose to do a fellowship up in Michigan at Beaumont Hospital. Okay. So Beaumont Hospital is in Royal Oak, Michigan. Okay. 13 mile. And it was a experience that combined everything that I loved about orthopedics. Okay. Which was the sports medicine side, including the knee and the shoulder. And then I also had a really excellent experience with shoulder replacement. Yeah. So I could take the shoulder from any small little problem to the biggest problem, from a labral repair to a reverse total shoulder. Okay. And so that means I see all ages of patients, which is really enjoyable too. And every different visit I have is going to be a new and exciting thing. Yeah. So if I have partners that do hips and knees, it's like, oh, that's all they do all day is hip replacements, knee replacements. Right. The same thing all the time. Yeah. I get to do a lot of different things, and I really enjoy that.
And when you say like different ages, are you treating kids also?
I am. So I won't do congenital problems because it's just not my area of expertise. Right. But kids that fracture their wrists or they fall and hurt their knee. And it's interesting, we're having so many more trouble with young people having really bad injuries, like ACL injuries, for example. The youngest I've treated is 10 years old.
Oh, wow. Okay.
And so that's a real problem, and it's a lot to do with muscular imbalances, playing sports really early, focusing on one sport at an excessively early point. We're not cross training very well.
Yeah.
And the focus on intensity as opposed to understanding sort of muscle balance and getting the kids strong.
Okay.
To reduce injury. So and I think the oldest patient I've ever treated is like 104. Which
Oh, wow.
amazing.
So from age 10 to age 104.
Yeah, exactly.
Is that, like, what is the majority of?
Majority is going to be, I think, bimodal, if you will, because I have my young patients that are injuring themselves in high school with their labral tears and shoulder dislocations.
Yeah.
And then and ACLs as well. And then I have my older patients that have the rotator cuff tears, that's chronic, and the ones that need their replacement.
Right.
And then you're going to get the weekends warriors. So I mean, maybe it's not bimodal. It really spans. I can have a clinic that is full. It might be a day of shoulders, and it's only the older rotator cuff tears. But generally, it's going to be a smattering, which is fun. Because it changes it up. And also the conversations change, right?
Yeah.
So if I'm talking to somebody about having their shoulder replaced, it's going to be a very different conversation in my 75-year-old that has had a chronic rotator cuff forever. Or my 49-year-old that can't move their shoulder because their arthritis is so bad.
Yeah.
I have really cool technology that I can use for young arthritic patients, which is coming around that we haven't had before. So different bearing surfaces, different types of replacements. It's just really exciting time to take care of patients.
So I'm 40. I'm turning 41.
Yes.
I do play cricket.
Yes.
Let's say I injure it.
Yeah.
What do and let's say it's a rotator cuff.
Sure.
I come to you.
Yes.
What should I expect?
So
you can make the injury.
This is the injury you had is when you fell and you were fine and then you weren't fine.
Right.
So then we're looking at an acute rotator cuff tendon tear.
Yes.
And an acute tendon tear can be very different than a chronic tendon tear. And that's a very important distinction to make.
Okay.
Because that can help me really identify how to help the patient.
Right.
So if a patient comes in, has what we assume to be acute tear, cannot move their arm because it's very, very weak because of the tear.
Right.
That is actually quick to the OR, which is interesting because that's not something that people always tie together.
Right.
But an acute tear, the data shows if you get to it very quick, like within 3 weeks, your likelihood of healing is excellent.
Okay.
So you want to do it quickly.
So the sooner better.
The sooner the better. Now, the opposite of that is a patient who may have had some aches and pains in their shoulder, but they're functioning just fine.
Yeah.
And then they have a fall, and then they can't move their arm at all, and someone gets an MRI, and you're like, oh, that's an enormous rotator cuff tendon tear. And guess what? There's also atrophy or muscle bulk loss.
So that's more like chronic.
Chronic, right?
Yeah.
So you know that's been there a while, and you know they probably had a tear already, and they may have aggravated it.
Okay.
When you have a tear that you compensate for over time, like little by little the fibers tear, your body really does a great job, not always, can really do a great job compensating. And when that occurs, you can get that person back sometimes without having to do surgery on them.
Right.
But then if they don't do well, we've done our due diligence, you've tried the therapy, maybe an injection.
Preservative treatment, right?
Right. You've done everything again. And sometimes people will just come back and like, look, I'm great. My arm moves. It's perfect. Your body's compensated. You have a compensated rotator cuff tear. We do not have to do anything.
Okay.
Alternatively, if they end up not doing well, then you can come back and then you can do a large rotator cuff repair.
Yeah.
You can use augmentation with allograft or 3D printed collagen, or there's these suture sheets that you can put on now that allow us to move people faster.
Right.
Alternatively, it may be a person that can't lift their arm at all. They may need a shoulder replacement.
Okay.
So one type of injury can be treated so many different ways, which is the most exciting thing. And it's like I get to be a detective, but what patient is this with this tear? Like, what do I have to do to make this patient do really great? Okay. And it's really exciting.
So same scenario. I got that injury.
Yep.
We did the surgery.
Yep.
What's my recovery time?
Great question. Depends on a few things. The size of the tear, the location of the tear. If we have a very standard tear.
The grade of the tear.
Yeah, so let's say you have a supraspinatus tear, which is the tendon at the top front.
Yeah.
The most commonly torn rotator cuff tendon. Say you have a full thickness, full width tear of the supraspinatus, and it's acute. I'm going to get you fixed up. I'm probably not going to have to put an augment on there, right? Okay. Because there wasn't anything, the tissue we hope quality is good, okay?
Right.
So we don't have to put anything on there, and we'll keep you in a sling for about 2 to 4 weeks.
Okay.
Okay, so that sounds really different than what you may have heard, which is normally 6 weeks.
Yeah, longer durations.
Because there's a great study that shows that patients that have a supraspinatus tear specifically with or without a sling are going to be fine.
Okay.
I still use a sling at first because I want to make sure the patient is comfortable and not trying to do a bunch of reaching. Because we're still, even though we can not wear the sling, it doesn't mean you can throw it around and do a bunch of stuff with it. So there's still some activity modification.
You got to take it easy still.
You got to take it easy.
Right.
But more often than not, I'm watching patients very closely to make sure they don't get stiff. So there's a fine balance of mobility, but allowing people to heal.
Does that go in the direction of frozen shoulder?
Correct. Well, and it's post-surgical adhesive capsulitis post-surgical arthrofibrosis is a better terminology for that.
Yeah.
Arthrofibrosis is a post-surgical thing.
Got it.
Frozen shoulder or adcaps, adhesive capsulitis is more of a non-surgical problem, right?
Okay.
And that kind of changes your mindset about what you do. But we don't want to have that happen.
Yeah.
A little bit of stiffness at 3 months is okay. That means you're higher likelihood of healing.
Okay.
A lot of stiffness means
It's
you're
not okay.
fighting that until the year mark, and you don't want to do that.
And is your plan with the younger people, relatively younger than you, 75, 80-year-olds, is to get them back to, let's say, sports?
Yes.
So, like, for example, I met myself, but you do deal with a lot of athletes.
Yes.
Okay.
Yes.
So, and your aim there is not just to repair this, you want to get them back to doing what they like.
That is the best thing about my practice. I swear, to get somebody who can't do the sport that they want to do and they're back to their sport, it's so rewarding.
Yes.
And it kind of pushes me every day. And then that's not just your high school athlete, because obviously that's very important for the kid going from high school to college, and we have the summer to get them ready.
Yeah.
And you have to prepare them in any way you can. But then you also have your 80-year-old pickleball player that wants to back out on the court. I mean, it is a real thing.
I was about to say it. My next question would have been, like, pickleball craze, you probably get a lot of elbow.
It's interesting. I get a ton of shoulder.
Okay.
I get a lot. Achilles tendon ruptures are actually the highest right now from pickleball.
Yeah.
Pickleball is the fastest growing sport and therefore the fastest growing injury causing sport.
So pickleball is the fastest growing
sport in the United States.
Okay.
It's the
and
fastest
it causes the most injuries.
And it's keeping orthopedic surgeons alive. Like, we are working, because the thing about that is that many of these injuries do require something surgical. If you're thinking about pickleball in the sense of what's the chronic issue, lateral or medial epicondylitis, yes, absolutely possible. Tendonitis of the shoulder that don't need surgery.
I think I had it.
Yeah.
Like, because I had never used, I think, that angle.
The movement, right?
Yeah. And then it kind of got better after 6 weeks.
Yes.
And when it didn't do anything,
that's good.
It just got better.
That's good, because you're you're probably a majority of the people, but people that struggle with lateral epicondylitis, it is so painful.
It was painful.
It's really painful, and then if they don't stop doing it and rest accordingly, then it's like, the way I look at lateral epicondylitis or medial epicondylitis is almost like thinking about it like a little micro tears that have occurred. It's an overused picture, and if you don't let your body heal, you're going to continue to have problems.
I just couldn't play anymore,
So
and then we kind of had the vacation part.
Yep.
So we were traveling, and it got better.
Wonderful.
And it just worked out that way.
Also, it's interesting. I often find a lot of shoulder issues associated with patients that have the elbow problem, because you have to look at the foundation. Check the scapula out, check the shoulder out, you have to make sure that everything's working appropriately. And the more I do this, the more I realize no one's scapula works well. So the shoulder blade is the foundation of the shoulder, and there's so many abnormalities.
Yeah.
And if I can fix that, a lot of times the pain goes away. And I don't fix it personally. I get a good therapist to see the patient. Okay. And ultimately, I want to make sure that the surgery I do is going to be super effective.
Yeah.
So ruling out any patient that actually doesn't need surgery, I think behooves me. First of all, you're keeping a patient out of the operating room that doesn't need to be operated on. But you kind of have to have them buy into the fact that therapy can help. There are so many patients that don't want to
have therapy, right?
They don't want to waste the time.
Yeah.
But I kind of get it, because in some cases you're going to a place where you're sitting in a corner, someone's telling you to do exercise, they run to see 16 other people, and then they come back and they're like, oh, are you doing it? Are you done?
Yeah.
That's not the same thing as a hands-on manual therapy, identifying the problem.
Is that something that's happening in your clinic?
It's not, because we're so small. We don't have that. And actually, if you're talking business side of things, at my old practice, we did it, and it was very hard to make it profitable.
Okay.
It was nice, though, because I was able to run the physical therapy side of things. And from my perspective, I had really good hands-on work with a therapist, and it helped me create protocols and plans and adjust according to the patient.
Yeah, because they're right there.
They're right there.
Yeah.
That's really nice. But I would tell you also, from a small business perspective, for me, having relationships with therapists all over town is also very useful.
Okay.
Because they know they can call me about any patient that I have, or any patient that's not mine. And I'm super happy to guide, because not every surgeon wants to do that. And I get that. It's time consuming. But because it's going to help the patient, it's totally worth doing it. And plus, then you're making relationships with the therapist, and then you can understand, oh, this therapist likes to take care of this elbow thing. That one likes this shoulder.
And then you direct the patient out.
Yeah, and then I can get in the right place.
Okay.
That's really
And you had started off with saying that you do a holistic approach.
Yeah.
And I don't hear that from a lot of orthopedics.
Yeah.
Tell me a little bit about that.
So I look at health, and I try to live by what I preach.
Okay.
Right? I want people to eat well, exercise, try to get enough sleep. None of us do that. But especially with all the various things we have in our lives.
You got 4 kids.
I have 4 kids. So
yeah.
I'm not gonna lie. There are some things that I can't do as well as I would preach people to do.
Right.
But in general, when people come in, and you see this too, pain can come from so many places.
Yeah.
Whether it's physiological or it's psychological, and the overlap of things that happen in the clinic. And that kind of goes back to making sure you know why people have pain. If you have a really good diagnosis, then you can decide if surgery is necessary.
Got it.
If it doesn't match up quite right, then instead of it being a shoulder thing, look at the neck, right? Or look at the wrist when it's, you have to look and make sure you have ruled out all the other reasons.
Things, right.
And it's interesting how many times I've had patients share with me traumatic experiences from their past.
Yeah.
And understanding in the sense of patients that have chronic pain.
Yeah.
That explanation of, acute pain versus chronic pain is a very different animal.
Right.
And we need to understand where it's coming from. And you may have central
find the source.
sensitization, find the source. And sometimes you can't.
Yeah.
And so there's a book, The Body Keeps the Score, which I recommend to a lot of my patients.
Okay.
Who if you're a vet, it's probably more suited for you, but still, it just shows how your body may represent a pain from some past experiences that you had.
Right.
And for folks to understand that doesn't mean it's only in their head. It just means that their pain pathways are not working properly.
Okay.
Essentially, you have pain somewhere. Every stimulus that this area sees is being perceived as a really intense pain.
Okay.
So sometimes you have to work with therapy to break down that really imbalanced pain pathway.
Okay.
That works through having the right team.
Yeah.
So it may be a starting point where I see them, and I get them a pain specialist. I get them a really good physical therapist. We work on intermittent evaluations just to make sure we're making progress.
Right.
And that is a challenging patient for me.
Yeah.
But I sense that many of those patients do not get the time that they need with their other physicians.
That's true.
And so it's a starting point. Does it work all the time? No.
Yeah.
But it does sometimes. It does. And I'll hear things where people actually make adjustments, and we get the right therapist involved, and then they can get better.
And I think this is the same thing, just like you said with the therapist. You probably have now relationships within the city with the pain management people.
Correct.
And you know what one person can do better than the other.
Absolutely.
And that helps, because for us, when we started clinic, it was a very big challenge, and I think I'm still learning.
Yeah.
If this is this kind of pain, this specialist kind of does it, and I think that takes a while to have that relationship and experience.
It does. And the last thing is, you're referring to others is for the patient to have a bad experience,
Yeah.
right? So if you send somebody, you're showing that person, like, I trust this person.
Yeah,
and
yeah.
then if something goes wrong, then it feels like it's on you. Or listen,
It's on you.
It's on me. And I don't want that. I want the
Yeah.
patient to have a great experience. And that's why I've told my employees from the beginning to the end, the system right now is very broken, and people can't get in to communicate with their therapist or the primary doctor or whatever. And I want my small little clinic to stay small and tight so that when a patient calls, they can get through. And then it's like, you need to hear from your spine surgeon? Like, we'll send them or her a text message. Like, here we go. Right? I'll make sure that because I don't want patients to struggle. If you see your family and they're struggling getting a hold of their physicians, or can't talk to anybody, it hurts my heart. And I don't want any patient to have that.
Yeah.
So as off topic as that is from an orthopedic perspective in general, it's just how I want to practice and make sure the patients get cared for, because I take it to heart. If I have a patient that I don't think I can make better, I want to find a place where they might be able to. So I will refer to mental health as well. So I have a sort of a pathway for mental health, that pain specialist we're talking about, if we're talking about physical therapy. So it's a combination of things. And it works sometimes, like I said, but not always.
No, I think I get the idea, because with the small business component, I think we're trying to build the same thing.
Right.
That was the whole idea. And just like you said, if I send somebody to a referral and they don't have a good experience, I kind of feel like I put them down.
Yeah, right.
But it's good to see that still there's some practices doing that, because I feel like now it's become more of a corporate business.
Absolutely.
And you don't really the patients don't get to see the physician or talk to them. Mm-hmm. So it's good and a fresh feel to have that still notion. I think that was how medicine was practiced in the older times, as you would put it. So it's good to have that.
Well, one of the things I think it's interesting about that sense is because we also talk about burnout in physicians and how real that is. And I think if I think about where I'm at now and where I was when I first started my practice, and I so much love what I do.
Yeah.
I get to go fix people. It is the most amazing, rewarding thing in the whole wide world. Is there a lot of stress? 100%.
Yeah.
But I'm not burnt out. And I think I'm not burnt out because I don't have a corporation telling me I must do this many cases, I must see this many patients, I get the control of that.
Yeah.
And I think that means a lot.
Oh yeah.
So
we're experiencing that, and it's a big change.
Yeah.
We love it.
It's lovely.
One of the topics that we had talked about, and I think it's a relatively newer topic, it's still being explored. I think the regenerative medicine, some people are doing stem cells parts. Is there any experience that you're running into that or doing something of that sort?
I look at it as biologics in general.
Okay.
So we have a lot of patients that have pain and we want to remove or reduce the pain so they then get stronger to support the joint.
Yeah.
So what are our options? I'll kind of go through that. We have corticosteroids are the most commonly used, just straight up injection that we use.
Yeah.
Everyone can do that. And we use them, but we want to use them sparingly. Because over time, the more injections you have, the more you soften soft tissue, cartilage, and bone.
Right.
So that can create damage.
Yeah.
And we're trying to avoid harm, right?
Right.
In the right setting, it can be a very useful tool.
Okay.
But it shouldn't be overused.
Okay.
So if we have other problems like tendinitis, let's look at that. For example, a patient is really not getting better with our measurements so far, physical therapy. We can consider something like a platelet-rich plasma injection.
Okay.
I tend to use it in patients that have not improved with the conservative treatment thus far and maybe don't want a corticosteroid, or maybe the corticosteroid injection lasted but was only short term.
Yeah.
But they still don't need physical, or still don't need surgery.
Right.
So with that, you can inject into the area like around the rotator cuff, and that can
Okay.
be helpful to reduce inflammation in a safe way, and it adds growth factors to the area.
Okay.
The data on that is pretty good, and it's interesting because we could also consider this in the use of arthritic pain. So arthritic shoulders, arthritic knees, and you can inject right in the joint.
Okay.
When I'm talking about those two type of injections that I just listed, we're not injecting into tendons or ligaments at that point.
Okay.
And recovery from injection like that is pretty straightforward. I normally add physical therapy so that the patient can get moving and then slowly build the muscle around the joint.
Got it.
And looking at adjacent joints above and below. There's also another use of PRP where we can look at a maybe partially torn rotator cuff tendon.
Yeah.
But it has to be a very specific kind where it's intersubstance.
Okay.
And if you inject in that tendon, in that region, you may see some improvement. I've actually seen MRIs before and after.
Okay.
And I've seen improvement in the tendon quality.
Yeah.
Which is pretty exciting. Now, the difference there is that intra-tendinous injections, they don't feel very good. It's a little uncomfortable to do for the patient.
Yeah.
More painful. And actually, to note is before you do any PRP injection, you have to be off NSAIDs for 2 weeks before and 2 weeks after, because we want the platelets to actually work.
Okay.
Otherwise, you don't get as much benefit from that.
Yeah, that's a valid point.
There may be some argument from certain experts on that, but that's sort of the way that I go about it, because I'm trying to make sure that I want the platelets to do their job.
Yeah.
They need to release and they have all our growth factors where they're supposed to be. So that's the idea there. And then you can use them for ligaments. So a lot of my UCL injuries that I see, I've been able to avoid surgery, and it's the right rehab protocol for sure, the right limitations, because it's a lot of these young kids that are playing and throwing, pitching since they're like 4 years old.
Yeah.
So again, you have to look at the shoulder, you have to look at the shoulder blade, and then you have to look at the elbow. And so in these acute on chronic issues, the PRP might be a helpful.
Do you foresee, like, as time goes by, like we said, it's 2025, this becoming more of a common in other practices?
It seems like it should be, because
I feel like it's more internationally rather than United States.
Right.
I see more being used outside.
Yeah, and then you're thinking about different things where you can manipulate more than we can.
Yeah.
So if we do any sort of stem cells at all, we can do things like adipose-derived stem cells, which is taking the fat and cleaning it, but like just you can't do anything to it, and then you can inject. And so that's the most stem cells we can get from the human. Right. You can do bone marrow aspirate as well. So in the operating room, I may use some of those options. So PRP, so platelet-rich plasma, bone marrow aspirate, and adipose-derived stem cells.
Yeah.
Those can be utilized in an additional way to get biology into a repair. For example, rotator cuff tears. Rotator cuff tears, as we mentioned earlier, your re-tear rate can be 0 to 95%. So if we have a patient that's a high risk for re-tear, we need to add to that. We need to supplement.
So we can help the growth.
Right, so we can help with the growth. So injections may be part of that.
Yeah.
At the time of surgery, as well as augments that I talked about earlier.
Okay. Yeah. All right, so Jamie, you've done a lot of shoulders, and I think you wanted to talk about a little bit of advancements there. Tell us.
So there's a lot of things that have changed since I started operating in 2012 with respect to the shoulder.
Okay.
It's changed dramatically, actually. We can focus on anatomic total shoulders versus reverse total shoulders, which is where we take the shoulder, make it look like the standard position of the normal shoulder. We just replace the bearing surfaces.
Okay.
That's great. That's an anatomic total shoulder. And one of the most challenging patients that we have is a young patient with arthritis. Okay. Because we have data that knee replacements are going to live 30 years, right? They're going to be great. Shoulders don't last that long. We have about 95% maintenance at like 10 years, right?
Okay.
That sounds okay for 10 years, but we want it to keep going.
Keep going, yeah.
And part of that is because of the bearing surface that we're using. So there is a newer bearing surface has been used in Australia and Europe for much longer.
Okay.
And it's called pyrocarbon. And pyrocarbon will at this point looks like it's allowing us to put a partial replacement in someone.
Okay.
Which means we don't have to put anything on the socket side.
Okay.
And if I orient you, the socket side is where the implants wear out.
Okay.
So if we can leave that alone, but make pain go away and get a patient that had no motion to have motion without pain, like it's amazing.
Yeah.
And it minimizes our risks in the future.
Okay.
So that's one of the things we're working on right now. In general, with the replacements, I preoperatively plan every single case. So that means I get a CT scan and I create a 3D version of that patient's implant, and I get to do the surgery before I do the surgery.
Okay.
So I can look at any pitfalls that may pop up and their anatomy, and just prepare, and it's really great. We know visualization helps, but if I can actually see it it's really great.
Yeah.
And then I can make sure that I have the right implant. So size-wise for a patient, you may look at a patient and say, oh, that's a big patient. Then you take your bones out and you're like, whoa, this isn't going to fit. So you're just trying to find the optimal implant for the patient.
Okay.
And so in the operating room, we can guide it in different ways as well.
Yeah.
So I've used mixed reality in the operating room, which helps me see the preoperative plan and then right next to the patient's body. Because in a surgery, you have a lot of soft tissue around the patient's shoulder, but when you're planning, there's none there. So having it all together helps you identify where the right places for this part of the implant.
It's like working like an Iron Man.
It's pretty cool.
Yeah.
And so I'll be in the aura bay and doing stuff like this and be like, what is going on in there? Because I'm the only one who can see the hologram.
Yeah, but
it's really cool.
But that technology part is or has to be integrated, right?
It has to be integrated. And that we are still sort of perfecting that.
Okay.
We're using, robots have been used in knees and hips.
Okay.
And we're just starting to incorporate that into shoulders.
Okay.
And it's not something that's used a lot yet, but the idea is we can create this perfect plan, but how do we execute it?
Okay.
How do we make it much more precise in the operating room?
Right.
And I spend time right now meticulously measuring things.
Yeah.
But if I could have a machine just be like, oh, there's a haptic. Yep, that's exactly where it's supposed to be. Boom, drill.
Right.
So it's kind of nice to have that. This is coming along. It's coming down the path.
Okay.
That's why being in shoulder is so neat, because it's constantly changing and getting better. And we have more to offer our patients.
Yeah.
You may have some primaries that say, oh my gosh, total shoulder, don't do that. It's terrible. The outcomes are awful. That's not true anymore. Like, they can do really well.
Now the outcomes are much better.
Yes, much better.
All right. I have some questions which were made by my partner. His name is Dr. Faraz. He's not here, but he does all of our rapid fire questions.
Okay.
So I'm going to try that with you.
Great.
So let's see a rapid fire round with an orthopedic. All right. So the first one, and you can answer them more like this one or not, yes or no.
I can defer if I prefer.
Yeah, you can call a friend. Amanda might be available.
She'll answer for me.
All right. So first question: knee replacement or hip replacement? What is more common, do you think?
Hip replacement.
Okay. How long should someone wait before considering surgery for chronic joint pain?
That's
like a broad
that's a
question.
great question.
Yeah.
I would say I don't have a time. I have do your physical therapy.
Okay.
Make sure you've lost the appropriate amount of weight and your
Yeah.
muscles are strong. And then you can decide if you still have
That brings me to a question. So weight is important for shoulder surgeries too.
The data is somewhat unclear. There's some studies that show that it makes a difference in outcomes, but what it has shown generally is there's often more comorbidities, and those comorbidities put people at higher risk for complications.
Okay.
So make sure
Even if it's not a gravity-based hip.
correct. Even though you're not
knee.
weight bearing
Yeah.
on it, it can make a difference. But in general, we were talking about, I was taking chronic joint pain in general because I do see knees and I do see hips.
Yeah.
But when you have chronic pain, again, we need to find the diagnosis.
Right.
And we need to find out and make sure we haven't missed something. So you might have knee pain, it's actually coming from your hip.
Okay.
Right? You may have hip pain, it's actually coming from your back.
Yeah.
Shoulder, it's coming from your neck. So you have to look at all those things.
Right.
Even if a shoulder looks bad, if the neck also looks concerning, I'm going to evaluate that. And then I talk to the patient, hey, if we fix this terrible looking shoulder, which we know it's terrible,
Right.
if it doesn't get better, I got to look north. So would you like to do that first? Or would you just fix the shoulder? And oftentimes it's consent with the patient, understanding the risks and the benefits.
Again, finding the source.
Yeah, finding the source.
All right. This one I like. What's one tip to keep your joint healthy as you age?
Stay strong. Motion is lotion, and stay strong. That's
Okay.
two. It's so important.
Motion's lotion.
Motion is lotion.
Okay.
If you don't move your joint, it's going to hurt. I don't care if you have a totally normal elbow. If you lock it up in a sling because something else hurts, your elbow's going to hurt.
I'm going to use that. Motion
is lotion. And patients remember it. They'll come back years later. You told me motion is lotion. And I remember, well, good for you.
Did you make it up?
No.
I was going to say it's yours. All right.
I don't even know where it came from, but I use it all the time, and people may think I made it up because I say it all the time.
All right. What is the most rewarding part of your orthopedic practice?
Fixing people's pain and dysfunction.
Yeah.
It's the best. People come in and can do things that I had a patient, and it was so amazing. We did a tendon transfer for her. She had a massive rotator cuff tear, her shoulder hurt, she couldn't lift, she couldn't move it. I took a small piece of her lower trapezius.
Okay.
I had an allograft, wrapped it around deep inside the shoulder, and then she went from not being able to move her shoulder to move her shoulder.
Yeah.
And she can hold her grandkids, and she's so happy.
Yeah.
And so things like that. Or a patient has been in chronic pain for their shoulder arthritis, and then you replace it. And then they'll say something like, I wish I would have done this earlier. It's just, it's so rewarding. And I'll tell you, when you put so much into your patients, which you do as well, you have to be careful about the joy you receive from doing that and getting that, because that's not always there, right?
Yeah, yeah.
And that's something I had to learn over time,
right.
Because you get so excited, and then all the things that people might have problems, like they started doing stuff way too early and they retore their rotator cuff because they didn't listen. Right. You can't put that on yourself. Right. You can only guide your patients. And that's important.
How to differentiate is probably important for our own mental health.
Absolutely.
Yeah.
Otherwise you burn out.
Favorite activity you recommend to strengthen joints?
Weightlifting.
Okay.
It has to be done well, but it can make a big difference. And within that, it's also functional movement too.
Okay.
So I just really like weightlifting personally. I enjoy it.
Yeah.
You get the muscle burn. I'm trying to tell patients to love it. They don't love it. In general, feel that burn 2 days later, like I did it. I made it really well. So that's.
Got it. I think I need to hit the gym. My partner, doctor who's there, has been asking me to do that. So I should start that.
It's worth it. It's totally worth it.
All right. Last question. If you weren't an orthopedic surgeon, what would you be?
Oh my gosh, that's such a hard question because I don't know it. I would not be as passionate about it, but I think I would be involved in wellness to some extent.
Okay.
Because I see how much we have done to hurt ourselves.
Okay.
By what we put in our bodies and how we don't move our bodies and how it has such a drastic effect on our emotions and how we treat others and how we've propagated this problem through our children.
Right.
And it's really sad.
Yeah.
And so I would probably have to find something there. But for me, I love the interaction with patients. Yeah. But my happy place is in the OR, fixing a shoulder. And there's no way I can, even the hard ones, like really challenging ones, glutton for punishment, I guess. But at the end of that, you're like, look what we just did. And there's nothing that compares.
So basically, it would be still an orthopedic. It would
have to be an orthopedics. And then also the other thing, which is interesting, is being with my kids. Yeah. I never thought I was going to have kids. I have 4 of them now. Right. Right. So when you have this, like, the most pure happiness from these little children, it may be one moment. Yeah. There's a lot of other moments, but there's so much joy that comes from that. Yeah. And there's no way to describe it unless you have kids.
Exactly. Awesome. I think I had no idea that I would feel that
I had no idea.
Till the kids, yeah.
Right, I was like, no, I don't need kids, I'm good.
And you always fight that till you have the kids. Right. Like, no, I'm not going to feel that.
But that's never. But I mean, with these 4 little humans that count on me for absolutely everything, my husband, of course. Yeah. And then for me wanting to make these little girls know that they can be powerful and do whatever they want. Yeah. And then my husband was like, yeah, but you want them to listen. I'm like, yeah, I know. We're really struggling with the balance. We don't know how we have the balance right now. Yeah. They're definitely powerful.
So those were the rapid fire. Yeah. We talked a little bit more than rapid fire. Jamie, if patient want to find you guys. Yes. Where's the office? How do they contact you if there's any information?
We are at the Spine Hospital in the medical office building, and it is right in the door. 101 is our suite number, but online, if you find True Ortho. .us. We're right there. And I also have a webpage too. So drjamielynch.com. That's mine. And it'll link you through both of them. Perfect. But if you need anything, you can go online and use a chat bot to contact us. I mean, we try to make it as easy as possible.
Perfect. Well, Jamie, thank you. Thank you for giving us time. It was a pleasure.
Thank you.
Thank you.
What fun.